Welcome back to the Deep Dive. Today we're really embarking on quite an intense mission, I think. We're aiming for what you might call an elite professional understanding of the surgical anatomy for two key heart valves, the mitral and the tricuspid.
Yeah, definitely challenging territory.
Exactly. We want to move past just knowing the terms. The goal here is real mastery, the kind that actually informs how surgery is planned, how it succeeds, and, crucially, how it's done safely.
That's right. And we're diving straight into, well, basically the blueprints that cardiac surgeons use. The sources are dense, taken from surgical texts where, frankly, every single millimeter counts.
High stakes.
Absolutely. So the idea is to translate that often flat, kind of two-dimensional knowledge you get from a book into something functional, something you can visualize in 3D, something actionable.
Right.
By the time we're done, you'll understand that the line between a successful life-saving repair and a critical complication can literally boil down to just how deep your grasp of this anatomy really is.
And thinking about the mitral valve specifically, the difficulty starts way before you even, touch the valve itself, doesn't it? Just where it is poses a huge problem.
It really does. I mean, the mitral valve sits right in the center, but it's completely tucked away posterior to the main bulk of the heart, behind the great vessels.
Like the engine core?
Pretty much. It's right at the heart of the engine, as you say. And because it handles the entire output of the left ventricle, well, there's no way around it. We have to use cardiopulmonary bypass.
So stop the heart completely.
Stop the heart, exclude it from circulation, just to get a proper look at the valve. And even then, even with the heart still, the surgeon needs specialized techniques, careful retraction of nearby structures, just to get adequate, clear, distortion-free exposure of everything. The leaflets, the anulus, all the bits underneath.
So, okay, before we get into the valves themselves, we need to talk about the foundation they sit on. That's the fibrous skeleton of the heart.
Right. Correct. That's the essential starting point. We often discuss the aortic, mitral, and tricuspid valves like they're separate items.
Yeah.
But structurally, from an engineering standpoint, what's really fascinating is they're not separate at all. They're connected. They form this single, continuous, interconnected structure.
Wow.
And they're tied together by this fibrous skeleton, which is basically arranged like a stabilizing triangle right at the base of the heart.
So that means how the mitral valve works, for example, isn't just about the mitral valve itself. It's physically tied to, say, the aortic valve structure.
Absolutely. This triangular fibrous core gives essential structural strength, especially important on the left side where the pressures are so high. It provides rigidity.
Okay.
Now, the interesting outlier here, the one valve that doesn't play along, is the pulmonary valve. It's totally separate and sits much more towards the front of the heart anteriorly.
Okay, so you have this rigid core, this triangle. But the heart itself is all about movement, stretching, contracting, changing volume all the time.
Yeah.
How does that rigid skeleton cope with those huge hemodynamic forces? And how does that interaction lead to valve failure over time?
Now that gets us to probably the single most critical concept if you want to understand atrioventricular valve disease. It's the idea of the non-homogeneous annulus.
Non-homogeneous.
Yeah.
Meaning not the same all the way around.
Exactly. Think about the aortic valve, high pressure, needs to be stable. The fibrous skeleton completely surrounds it, fully encloses it. But, and this is the crucial bit, it only partially encloses the mitral and tricuspid valves.
Okay.
So the annulus, the ring that the valve leaflet's attached to, it isn't a solid, uniform ring of tough tissue. It's more like a mosaic.
A patchwork, like bits of different material.
Precisely. That's a great way to put it. The annulus is made up of some dense, rigid, fibrous tissue, mainly where it connects to that central fibrous body and the trigones, the anchor points, and also highly elastic, stretchy, muscular tissue, especially along the back edge, the posterior attachments. This difference is absolutely paramount.
So, okay, let's say the left ventricle starts to fail, pressure builds up, volume backs up into the left atrium. That force doesn't hit the whole ring evenly.
Nope. And that is the core pathology. That non-uniform structure is the exact reason why overload causes asymmetrical dilation.
Ah, I see.
The rigid fibrous parts, they stay put, they don't stretch. But the muscular bits next to them, they stretch out, sometimes severely under that load.
And if that pressure stays high?
Then what starts as a reversible stretch becomes progressive. It leads to irreversible distortion, chronic valve failure. The whole geometry gets messed up permanently, and that stops the leaflets from coming together properly, from coapting. That's your leak.
Wow. That insight really changes things. It connects this tiny anatomical detail, the mix of tissues, directly to why the valve fails on a large scale. And I guess it tells the surgeon exactly what needs fixing, right? Often it's about reinforcing that stretched out muscular part.
Exactly. The fix has to address the specific anatomical failure.
Okay, let's step back for a second to the clinical picture.
Yeah.
How big a problem is valve disease?
Well, just looking at the scale, it's huge. Valve disease is really common, affects something like 2 to 5% of the population in places like the UK, and that number just climbs dramatically as people get older.
And for the mitral valves specifically?
The most common issue is degenerative disease, which leads to mitral valve prolapse, where the leaflets sort of bulge back.
Right, I've heard of that.
It's common, but the key thing is about 1 in 10 people with prolapse will eventually develop severe regurgitation, a bad leak that needs surgery.
Okay, so surgery becomes necessary. What are the options then? Repair versus replacement.
And here, the evidence, especially for degenerative disease, is just overwhelming now. Repair is superior to replacement.
Really? How so?
The data is really solid. Surgical mitral valve repair leads to better survival right after the operation, significantly lower risk of stroke compared to putting in a new valve, better long-term survival down the road, and this is important, much lower rates of needing another operation later on.
So the goal is always to keep the patient's own valve if possible.
Absolutely. Preserve the native components whenever you can.
But it sounds like repair isn't easy. The sources mention it takes exceptional skill.
Oh, it absolutely does. It's technically demanding. For a repair to be considered successful and, importantly, durable, the surgeon has to nail 3 core anatomical principles.
Okay, what are they?
First, they have to achieve complete restoration of the annular geometry, get that ring back to its proper shape and size.
Makes sense, given the dilation problem.
Second, they need to ensure the restoration of normal leaflet motion. The leaflets have to open and close freely and correctly. And third, they must create a large surface area of coaptation between those leaflets when they close.
Coaptation, that's the sealing surface.
That's the seal. The bigger the overlap, the better the seal, the more durable the repair.
So really, every anatomical detail we're about to get into the shape of the ring, those trigone anchor points, the little cords, the muscles, they're all tools the surgeon needs to understand intimately to hit those 3 targets.
Precisely. You can't achieve those goals without mastering the anatomy. We're essentially mapping the defect, the distortion, so we can then map out the fix, which is rebuilding that original perfect architecture.
Okay, let's dive into the mitral valve itself then. You described it as a dynamic functional unit. What are the components?
There are 5 interconnected parts that work together. The leaflets and the commissures where they meet, the anulus or ring they attach to, the chordae, tendineae, those stringy bits, and the papillary muscles they connect to down in the ventricle.
And it's incredibly dynamic, isn't it?
It's a phenomenal piece of biological engineering. Just think about how fast and complex its job is. In diastole, when the heart relaxes, the leaflets have to swing wide open, completely out of the way, so blood flows through without obstruction.
Okay.
They even help direct that high-speed jet of blood down towards the apex, the bottom tip of the heart, which actually helps set up the flow pattern for the next beat.
And then when the heart squeezes in systole, it's not just passively shutting.
Not at all. It's an incredibly active, coordinated sequence. The process actually starts with the papillary muscles contracting. They don't wait for the pressure to build up.
Really? They go first?
They go first. They actively pull on the chordae to pull the leaflets into position opposite each other, creating that initial seal before the main squeeze. Then, once they're positioned, the huge pressure from the left ventricle pushes the leaflets tightly together, achieving that competent leak-proof closure. But remember, the main force holding back that systolic pressure isn't the chordae pulling, it's that large surface area of coaptation we mentioned. The overlap is key. The muscles and cords also help shape the outflow tract, making sure blood goes smoothly out to the aorta.
Okay, let's dissect the leaflets themselves.
Yeah.
You mentioned a fundamental asymmetry in how they attach.
Yes, this is really important. Even though the 2 main leaflets, the anterior and posterior, have roughly the same total surface area, how they attach to the annulus is completely different.
How so?
The anterior leaflet only attaches to about 1/3 of the ring's circumference, but the posterior leaflet attaches to the remaining 2/3.
2/3, that's a huge difference.
It is, and that ratio basically dictates everything about how they look and how they move.
So the wider attachment must sort of restrict the posterior leaflet, while the narrow one lets the anterior leaflet move more freely.
Exactly right. The anterior leaflet is narrower but much longer, sort of like a veil. Its narrow attachment lets it swing very freely, like on a simple hinge. It's the main regulator of flow.
Okay.
The posterior leaflet, because it's attached so broadly, has to be wider and shorter. And critically, because it's attached along such a long curve, it needs multiple scallops, little indentations or curves along its free edge,
Why a scallop?
to allow it to open fully. If it were just one solid, wide curtain attached over 2/3 of the ring, it couldn't physically open properly without bunching up and blocking blood flow into the ventricle. The scallops give it the flexibility to fold open efficiently.
And these scallops are important landmarks for surgeons, I imagine.
Absolutely. They're the geographical reference points.
Right.
Typically, the posterior leaflet has 3 main scallops. We name them P1, which is anterolateral, P2 in the middle, and P3, which is posteromedial.
P1, P2, P3.
Got it. And we use corresponding terms for the areas on the anterior leaflet opposite them, A1, A2, and A3, although usually in a healthy valve, the anterior leaflet doesn't have distinct scallops dividing these areas. It's smoother.
And is one scallop more prone to problems than others?
Yes, P2, that central posterior scallop, is very often the area that prolapses or fails first in common degenerative mitral valve disease.
Okay. And what about the leaflet tissue itself? You mentioned functional zones.
Yes, another crucial distinction. Each leaflet has 2 zones. The atrial zone is the part closest to the atrium. It's thin, smooth, almost translucent. It's mainly designed for flexibility, allowing the leaflet to open fully.
And the other zone?
That's the critical one for function. The coaptation zone. This is the area further down towards the edge that actually makes contact with the opposing leaflet during systole. It's rougher, thicker tissue.
So that's the business end, the sealing surface.
Exactly. The coaptation zone is the functional seal. Its size and integrity are what determine if the valve leaks or not and how durable the repair will be.
Okay. Lastly, for the leaflets, what about the commissures? The points where the anterior and posterior leaflets meet.
Right. You have the anterolateral and posteromedial commissures. They separate the main bodies of the leaflets. But the key anatomical point here is that they don't actually extend all the way back to the valve hinge, to the fibrous skeleton itself.
Why is that important?
It ensures there's competent continuity between the leaflets right out to the edges. It prevents little leaks from forming at the corners during high-pressure systole. It maintains the structural integrity of the closure.
Fascinating detail. Okay, let's move to the annulus itself. We know it's non-homogeneous, part fibrous, part muscular. But what about its 3D shape? You said it's not just the flat ring.
No, definitely not flat. It's complex. The mitral annulus actually has a dynamic saddle-shaped configuration.
Saddle-shaped, like a Pringle.
Yeah, sort of like that. It dips lowest at the points where it's anchored firmly, those are the trigones, and then it arches highest in the middle sections, roughly corresponding to the A2 and P2 leaflet segments.
And why the saddle shape?
It's thought to be essential for maintaining mechanical strength and minimizing stress on the leaflets when the valve closes under high pressure. It distributes the forces more effectively than a flat ring would.
And you mentioned it's dynamic, so that shape changes during the heartbeat.
It does. When the valve is wide open and diastole, letting blood fill the ventricle, the opening, the orifice, becomes rounder, almost circular.
Okay.
But then, when the heart contracts in systole and the valve closes, the annulus actually constricts and changes shape. It becomes flatter and somewhat squarer. A successful repair has to allow for, and ideally restore, that dynamic shape change.
Right. Now, you mentioned the anchor points, the fibrous trigones. Something called the aortomitral curtain.
Yes. The anterolateral and posteromedial fibrous trigones are these key dense spots in the fibrous skeleton. Think of them as the immovable, rigid anchors of the valve, particularly framing where the anterior leaflet attaches.
Okay.
And running between these trigones, right next to the hinge line of the anterior leaflet, is this really vital and quite delicate structure called the aortomitral curtain.
The curtain. Tell me more about that. What's its structural role?
It's extremely significant. This is a very thin, fibrous sheet of tissue. It connects the middle part of the anterior mitral leaflet hinge directly up to the annulus of the aortic valve. Specifically, it sits just underneath the non-coronary cusp of the aortic valve.
So it physically links the mitral and aortic valves.
Precisely. The aortomitral curtain is the structural continuity point between these two high-pressure fibrous rings, the aortic and the mitral. Functionally, it doesn't stretch. And this is critical for surgery because it strictly limits how and where a surgeon can place sutures along that anterior part of the mitral annulus. You can't just pull it tighter, for instance.
Okay, this brings us right back to that asymmetrical dilation we discussed. If we use the trigones as fixed reference points, how does the valve distort in disease?
Right, so imagine the healthy annulus as roughly a D shape. where the straight part of the D is that fibrous intertrigonal distance defined by the two trigones and the aortomitral curtain.
Okay, the fixed part.
Exactly. That part, the intertrigonal distance, T in a diagrams, being fibrous, stays constant. It doesn't stretch. All the dilation, all the stretching happens along the curved part of the D that's the posterior two-thirds attachment, which is mostly muscular and elastic, the vertical diameter A.
Ah.
So that posterior segment stretches outwards, pulls away from the center.
So the valve goes from that tight D shape held by the trigones into this stretched out, baggy, pathological oval shape.
Exactly. And that's why annuloplasty rings, the devices surgeons use to repair the annulus, are shaped the way they are. They're designed specifically to cinch down and remodel that stretched posterior segment while leaving the fixed fibrous intertrigonal distance alone. The repair has to perfectly mirror the anatomical failure.
That makes so much sense now. Okay, let's move down under the leaflets to the subvalvular apparatus, the papillary muscles, and the chordae.
Right. Their job, working together, is firstly to allow the leaflets to open fully and actively during diastole, and then critically to position the leaflets precisely for perfect coaptation when the ventricle squeezes in systole.
The sources talk about two main groups of papillary muscles. Can you detail those, especially their blood supply? Because I gather that's a key vulnerability.
It absolutely is. First, you have the anterolateral papillary muscle. This one sits high up on the anterior wall of the left ventricle. It's usually the bigger, bulkier one.
Okay.
And crucially, it typically has a robust dual blood supply. It gets blood from branches of both the left anterior descending artery, the LAD, and the circumflex artery, the LCX.
Dual supply.
Yeah.
So it's well protected if one artery gets blocked.
Exactly. That redundancy gives it excellent protection against ischemia. Its chordae tendrils mostly go to the anterolateral parts of the leaflets around A1, A2, P1, P2.
Okay, what about the other group, the more vulnerable one?
That's the posteromedial papillary muscle group. This one sits lower down, sort of between the back wall and the septum, the wall dividing the ventricles. It's often more complex, maybe looking like 2 or 3 separate heads rather than one solid muscle.
And its blood supply.
This is the critical surgical and pathological point. It's supplied by either the circumflex artery or the right coronary artery, RCA, depending on the person's coronary dominance. But, and this is the key, it gets its supply in isolation. There's no backup, no redundant supply.
So just one vessel feeding it. That makes it the weak link if someone has a heart attack affecting that specific artery.
Precisely. If a patient has an infarct, a blockage, that hits that single supply vessel, the posteromedial papillary muscle group is way more likely to suffer ischemia, dysfunction, or even rupture.
Which would cause sudden severe mitral regurgitation.
Exactly. It's a major cause of acute mitral regurgitation after a heart attack. Knowing this is vital for emergency surgery. It's also interesting that the central part of the posterior leaflet, P2, usually gets chordae from both muscle groups, which helps make it a kind of central stabilizing zone.
Fascinating. Okay, let's focus on the chordae tendineae themselves, the heartstrings. We established their job is positioning the leaflets, not really fighting the main pressure. You need to break down the 3 types for us.
Right. The classification is based purely on where they attach to the leaflet. First, you have the primary chordae. These are the ones that attach right to the very margins, the free edges of the leaflets.
Okay.
When the valve opens, they sort of encircle the opening like a curtain fringe, ready to pull the edges together for closure.
Got it. What's the next level?
Second are the secondary chordae. These attach further back from the edge onto the ventricular underside of the main body of the leaflet.
And their job?
They support the main belly of the leaflet. They maintain the correct curvature and prevent the leaflet from bulging back too much, taking stress off that crucial coaptation zone during systole.
Okay. Primary at the edge, secondary on the underside. What are tertiary chordae?
Tertiary chordae. These attach mainly to the base of the posterior leaflet, near the annulus, and also in the commissural regions, the corners. What's interesting is they often don't come from the main papillary muddle heads. Sometimes they arise directly from the ventricular wall itself or even the annulus nearby.
What do they do?
They provide extra basal reinforcement, sort of tethering the base, especially important for that wide posterior leaflet segment. Understanding these 3 types is key for surgeons because if a valve is leaking, they need to identify exactly which chordal level has failed. Is it a broken primary cord letting the edge flail? Or a problem with secondary cords causing the leaflet body to prolapse or restrict? The repair targets the specific failed structure.
Right. Makes sense. Okay, we need to shift gears slightly and look at the related anatomy on the right side of the heart, starting with the tricuspid valve. It often gets less attention, but tricuspid regurgitation is a growing problem, isn't it? Often occurs secondary to left-sided issues.
That's absolutely right. It's increasingly recognized as important. Functionally, the tricuspid mirrors the mitral. In many ways, it has that smooth atrial zone and the rougher coaptation zone on its leaflets. But of course, it has 3 leaflets, not 2.
Tricuspid, 3 leaflets. Makes sense.
And the structure is inherently asymmetrical because one side is attached to the septum.
Okay, which are the 3 leaflets?
You have the anterior leaflet, which is usually the largest. Then there's the posterior leaflet, which attaches to about a third of the annulus, similar to the mitral's posterior leaflet in proportion, and it often has a couple of indentations, like small scallops, to help it open.
Okay.
And then, uniquely, there's the septal leaflet. This is the smallest one, and it's attached directly to the interventricular septum, the wall between the ventricles. You also often find little extra accessory leaflets in the commissures here.
And thinking about valve failure, does that asymmetrical dilation principle we talked about for the mitral valve apply here too? Does the tricuspid annulus stretch unevenly?
It absolutely does. When the right ventricle gets overloaded with pressure or volume, the tricuspid annulus also dilates asymmetrically.
How so?
The part attached near the aortic valve and the fibrous skeleton, and crucially, the part attached to the rigid septum, that tends to stay relatively fixed. The stretching happens primarily on the free wall portions, the anterior and posterior attachments. They bulge outwards.
So it reinforces that general rule for these atrioventricular valves. The stretchy muscular parts give way under load, leading to that geometric failure and leakage.
Exactly. It's the same fundamental principle at play.
Now, you mentioned the septal leaflet's unique attachment to the septum. How does that connect back to the heart's electrical system, the conduction system?
Yes. This creates a very specific surgical hazard. Because the septal leaflet attaches right next to the central fibrous body, it's immediately adjacent to the critical hub of the conduction system, specifically the AV node and the bundle of His, which carry the electrical signal down to the ventricles.
So operating on the tricuspid valve near the septum is risky.
Yes. Placing deep sutures into the septal part of the tricuspid annulus, maybe during a ring annuloplasty repair, carries a significantly higher risk of damaging those conduction tissues and causing heart block compared to working on the posterior free wall aspect of the mitral valve. It's a known danger zone.
Okay, that leads us perfectly into talking about the interatrial septum itself, the wall between the 2 atria. Since the standard way to get to the mitral valve is often through the right atrium and then cutting across this septum, knowing its anatomy inside out must be crucial for safe access.
Absolutely essential. If you're going transeptally, you need to know exactly where you are and what's around you.
So what are the key landmarks a surgeon looks for on that septal wall?
Well, the most obvious one is the fossa ovalis. That's the thin, depressed area in the center, which is the remnant of the hole that connects the atria in fetal life. That thing spot is usually the target for making the transeptal incision.
Okay. But you mentioned valve-like structures nearby.
Yes, there are 2 important ones guarding the entrances of major veins. First, guarding the opening where the inferior vena cava, the IVC, brings blood back from the lower body. You have the Eustachian valve.
Eustachian valve. Why does a surgeon need to know about that?
Usually it's small and insignificant, but sometimes it can be quite large or prominent. And if it is, it can actually get in the way and obstruct the surgeon when they're trying to insert the big cannula into the IVC to put the patient on cardiopulmonary bypass. So you need to be aware it might be there.
Okay. And the second valve, you said it relates to protecting the heart during surgery?
Correct. That's the Thebesian valve. It's a small fold that guards the entrance of the coronary sinus.
The coronary sinus, why is that important?
The coronary sinus is the big vein that collects most of the blood draining from the heart muscle itself. Surgically, it's a critical landmark because it's the standard place to insert a special catheter, the retrograde cardioplegia cannula.
Retrograde cardioplegia.
Yeah, it means delivering the cold, protective solution, the cardioplegia, that stops the heart and protects it backwards through the veins of the heart via the coronary sinus. So knowing where that opening is and that the Thebesian valve might partially cover it is essential for delivering cardioplegia effectively.
Okay, fossa ovalis, Eustachian valve, Thebesian valve. Now, how do these relate to the most critical danger zone on the right side, the triangle of Koch? You said this is where the conduction system is concentrated.
This is absolutely non-negotiable anatomical knowledge for any cardiac surgeon. The triangle of Koch is a small, specific anatomical area, and we need to know its borders precisely.
Okay, lay them out for us.
Border number 1 is the hinge line of the septal leaflet of the tricuspid valve, where that leaflet attaches to the septum.
Got it. Border 2.
Border number 2 is the opening of the coronary sinus, which we just discussed.
Okay. And the third side of the triangle?
That's formed by the tendon of Todaro. This is a little fibrous band or ridge that runs from the central fibrous body up towards the corner where the anterior and septal leaflets meet, the anteroseptal commissure.
So tricuspid septal hinge, coronary sinus opening, tendon of Todaro. What's inside that triangle right at its apex?
Precisely at the apex lies the atrioventricular node, AVN, the main junction box of the heart's electrical system. And from the AVN, the signal pathway continues down as the bundle of His. The surgical significance is huge. Any injury within this tiny triangle, whether it's from heat from cautery, mechanical damage from sutures, or even just pulling too hard during retraction, especially when working on the tricuspid valve near the septum, carries a direct risk of causing permanent heart block.
Meaning the patient would need a pacemaker.
Exactly. Permanent pacemaker implantation. So avoiding injury within Cox triangle is paramount.
Okay, let's tie this all together now in the context of the actual surgery. Phase 1 is getting adequate access. What's the goal here?
The goal is simple but challenging. Get complete, distortion-free visualization of everything related to the mitral valve. All 5 components, leaflets, annulus, the whole subvalvular apparatus, including both papillary muscles.
You need to see it clearly.
Not just when the heart is stopped and relaxed, but also clearly enough to assess it after the repair when the heart is beating and filled with blood to dynamically test the result.
And as you said, the standard approach often involves going across the septum, which is why knowing all that septal anatomy we just covered is so critical.
Precisely. The surgeon's choice of which specific incision to use depends entirely on how much exposure they need, how complex the valve problem is, and maybe the patient's specific anatomy, like the size of their atrium.
Okay, let's run through the main surgical approaches mentioned, starting with the most direct one.
The simplest is probably going directly through the left atrium. The incision is made in the groove between the right and left atria, just in front of where the pulmonary veins enter the left atrium.
And when would you use that?
It's quick, it's straightforward, and it often gives pretty good exposure if the patient already has an enlarged left atrium, which is actually quite common in people with chronic mitral valve disease. It can also be extended downwards behind the IVC if needed.
Okay, simple and direct. What if the case looks more complicated? Or maybe the surgeon wants to check the tricuspid valve first before deciding on the mitral repair.
Right, then they'll opt to go through the right atrium, which means they have to make a specific cut across the interatrial septum, a transeptal incision.
Okay.
And within that transeptal approach, there are a couple of main variations, both usually starting near the fossa ovalis. The first is the transeptal longitudinal incision. Here, the cut goes vertically upwards from the fossa ovalis towards the superior vena cava, SVC.
And the advantage?
It's a good intermediate step. It generally gives better access to the anterior part of the mitral annulus compared to the simple left atrial approach.
Okay. But what about the really tough cases? Reoperations, maybe patients with very small atria where exposure is difficult, or complex repairs for ischemic mitral regurgitation. What's the best approach then?
For those situations, the gold standard for maximal exposure is the transeptal oblique incision.
Oblique. So it runs diagonally.
Exactly. This is the longest and most extensive incision. It starts down at the fossa ovalis, but then extends diagonally upwards and across the roof of the left atrium, heading towards a point roughly midway between the aortic valve and the SVC. This approach provides truly unparalleled vision of the entire mitral apparatus.
Unparalleled vision. Why is that oblique cut so much better? What specific veer does it give the surgeon that the others might not?
Because it opens up the whole atrial roof so widely, it essentially allows the surgeon to look straight down, almost like looking into a funnel, getting an unconstrained view of the anterior leaflet. Yes, but critically, also the entire subvalvular apparatus, both papillary muscles and all the chordae.
Ah, so for complex repairs.
Exactly. If you're dealing with multiple ruptured chordae, or you need to assess subtle restrictions in how the posterior leaflet moves, or maybe do complex papillary muscle repositioning, that oblique view gives you the angle of attack and the space you need to see everything clearly without distortion and make sure the repair is geometrically perfect. It's often essential for those really challenging cases.
Okay, maximum exposure for maximum complexity. Now let's talk hazards. You've gained access, you're looking at the annulus, ready to place sutures for an annuloplasty ring perhaps.
Yeah.
What are the critical structures lurking nearby, hidden from direct view?
Right. This is where millimeters really matter and where deep anatomical knowledge prevents disaster. We're talking about vital structures lying incredibly close to the annulus, often just underneath the surface you're suturing.
Let's start with the big one, the most feared hazard, especially near that anterolateral commissure, P1, P2 region.
That has to be the circumflex coronary artery, LCX. As it comes around the heart, it runs in the groove between the base of the left atrial appendage and the mitral annulus, right near that anterolateral commissure.
And how close is it?
Frighteningly close. It typically lies only about 5 millimeters away from the actual hinge line of the mitral valve, especially along the posterior aspect near the P1 and P2 scallops.
5 millimeters. That's not much margin for error when you're putting in sutures to cinch down that stretched posterior annulus. So if a suture bite goes too deep,
If a suture is placed too deeply into that posterior muscular wall, trying to get a good hold to stabilize the ring, the risk is catastrophic injury to the circumflex artery, either tying it off completely, or ligation, or tearing it, laceration.
and the consequence.
Massive, often fatal heart attack involving the lateral and inferior walls of the left ventricle right after surgery. This is exactly why knowing the difference between the fibrous part of the annulus near the trigonose, where you can take deeper bites safely, and the muscular posterior part, where you must take shallow bites, is absolutely paramount.
So shallow bites posteriorly to avoid the artery. What happens if, despite precautions, that injury occurs? How do they know, and what's the response?
If the patient comes off bypass and suddenly shows signs of poor heart function, like unexpected low blood pressure, poor contractility on the echo, or significant ECG changes suggesting ischemia in that lateral wall territory, a circumflex injury has to be suspected immediately.
And the protocol.
Time is critical. The immediate response is usually an urgent coronary angiogram right there in the operating suite or hybrid room to visualize the artery and see if it's blocked or damaged. Or if things are crashing too fast, the surgeon might have to proceed directly to placing an emergency coronary artery bypass graft to restore blood flow to that circumflex territory immediately.
Wow. High stakes indeed. Okay, circumflex artery is hazard number 1. What about the venous structure that wraps around the posterior leaflet?
Right, that's the coronary sinus. It starts near the P1 scallop area and runs all the way around the back of the mitral annulus towards P3. Like the circumflex, it's also very close, running about 5 millimeters away from the mitral hinge posteriorly.
And the risk of damaging that?
Damaging the coronary sinus is also serious. It can cause significant bleeding or make it difficult or impossible to deliver that retrograde cardioplegia we talked about later in the case or in the future. However, while serious, an injury here is generally considered less acutely catastrophic than ligating the circumflex artery.
Okay, one more major danger zone. Near the anterior leaflet hinge, up by the fibrous trigones. This involves the aortic valve itself.
Yes, this relates directly back to that aortic mitral curtain we discussed, that thin fibrous sheet connecting the mitral and aortic valves. Remember, the aortic valve annulus and the aortic valve cusps themselves, specifically the non-coronary and left coronary cusps, are extremely close to the anterior mitral hinge line. We're talking only about 1 centimeter away.
So placing sutures deep in that anterior fibrous region is risky.
Very risky. If a surgeon is trying too aggressively, perhaps, to narrow the distance between the trogons, or simply places a suture too deeply near those trogons, adjacent to the anterior leaflet hinge,
What happened?
the suture needle can actually penetrate right through the aortomitral curtain and into the sinuses of the aortic root behind the aortic valve leaflets. This can directly damage an aortic leaflet or even stitch it partially or fully shut. Or it could cause catastrophic bleeding from the aorta. The sign you'd see immediately after coming off bypass would be sudden, severe aortic regurgitation, a massive leak back through the aortic valve visible on the transesophageal echo, TOE. The left ventricle might start to rapidly distend because it can't pump blood out effectively.
And the fix for that?
If the damage is severe and irreparable, the patient might suddenly need an emergency aortic valve replacement in addition to their planned mitral valve surgery. A terrible complication stemming from one misplaced suture.
Unbelievable. We need to quickly revisit the conduction system hazard one last time. We know the AV node is in the triangle of Koch over on the right side, but how does the bundle of His relate specifically to the mitral valve ring?
Good point. The bundle of His, which carries the signal down from the AV node, runs through the central fibrous body. While it's technically just outside the mitral annulus, it lies extremely close to, almost directly connected with, the posteromedial fibrous trigone, one of those key anchor points for the mitral valve.
So working near that specific trigone carries risk.
Yes. Any significant trauma, Excessive pulling or placing very deep sutures specifically aimed at stabilizing that rigid posteromedial trigone carries an inherent risk of injuring the bundle of his and causing heart block, just like near the septal leaflet of the tricuspid valve, although perhaps slightly less common. Still a critical structure to respect.
Okay, we've covered access, anatomy, hazards. Let's loop back to the goal. You mentioned one of the three principles of successful repair is creating a large surface area of coaptation. How is that measured? What defines success?
Right. Ultimately, the long-term durability and competency of the repaired valve depend heavily on how much the leaflets overlap when they close the depth of that coaptation zone.
More overlapped is better.
Absolutely. The greater the surface area of contact, the less stress is placed on any single point of the leaflet tissue, and the stronger and more resilient the repair will be over years.
Is there a specific threshold surgeons aim for?
Yes. The generally accepted standard surgical threshold, which absolutely must be demonstrated on the transesophageal echo after the heart has been restarted and is beating under normal pressures, is a minimum coaptation depth of 0.6 centimeters or 6 millimeters between the leaflets.
6 millimeters of overlap.
Achieving at least that 6 millimeter overlap is the functional goal that validates the anatomical reconstruction they just performed.
So the surgeon does the physical repair on the still heart, then they come off bypass, restart the heart, and use the live TOE probe in the esophagus to look at the valve working under pressure and measure that coaptation depth.
Exactly that. It's an immediate, real-time, high-pressure quality control check. If that echo shows the coaptation is insufficient, less than 0.6 centimeters, or if there's still a significant leak, the surgeon knows the repair isn't adequate. They may have to go back on bypass and revise the geometry, maybe tighten the ring more, maybe add artificial cords, whatever it takes to achieve that minimum depth before finally closing the chest.
A critical final check. This has been an incredible journey through some really complex anatomy. I feel like we've genuinely taken concepts that can feel abstract when you read them, like the anulus or the trigones, and turned them into this dynamic three-dimensional structure with these critical fixed fibrous parts and these specific stretching muscular segments. We've definitely moved from just definition to surgical reality.
I think that's the key takeaway. The overarching synthesis really is crystal clear. The way the valve fails, that asymmetrical dilation, the tendency for certain parts to prolapse, it's all entirely dictated by the underlying structural makeup, that mix of fibrous and muscular tissue in the valve skeleton.
Right.
And therefore, mastering this anatomy, truly knowing the 5 millimeter proximity of the circumflex, understanding the isolated blood supply that makes the posteromedial papillary muscles so vulnerable, pinpointing the exact borders of the triangle of Koch, that knowledge isn't academic. It is literally the difference between saving a life with a durable repair and causing a devastating, potentially irreversible complication.
A powerful summary. Thank you so much for guiding us through this. It was challenging, but absolutely essential detail.
My pleasure. It's fascinating stuff, even if it is complex.
Absolutely. Now, for you, the listener, to perhaps chew on this a bit further, we established that the bundle of his runs very close to that posteromedial fibrous trigone. Now, considering the trigone is a fixed fibrous structure that doesn't really stretch with dilation, think about this. How might chronic, maybe low-grade non-fatal inflammation or fibrosis, or even just microscarring that can occur with long-standing valve disease in that specific fibrous area, even without any surgical intervention, how might that subtly damage the nearby bundle of his over time and potentially predispose a patient to developing long-term progressive conduction problems like various degrees of heart block later in life? It's something to make you think about that interesting and maybe often overlooked link between structural heart disease and the heart's electrical function.